Okay, we're rolling. Great. So, okay. By necessity of this, I only have an hour to give you a neuroanatomy course. Now, my hope is that you have some understanding of neuroanatomy, because to do this properly would take about 30 to 50 hours of lectures. So what I've done is I've gone to my Medic Kids and I've tried to work out the stuff that you had on the first sit and the high yield stuff and put it into this talk. Fortunately, there are other talks that you can look at, and there's loads of resources online. But this is the high-yield stuff for this particular second sit that I think will be quite useful for you. So, not much time, as we said, so I'm going to have to cut things. Fortunately, there are 3 lectures. There's a stroke lecture, a lecture encompassing all of the descending tracts, and then upper versus lower motor neuron lesions. And there's also a lecture that encompasses the brain, the blood supply of the brain, which is also accompanied with the stroke lecture, and the anatomy of the skull and how all the cranial nerves get through it, the bits that you need to know. Those 3 lectures I recorded throughout the year when I was doing peer support, and I will link to those later if you're struggling with those particular things. This lecture will not include that content because you can access those videos in your own time. It's like the Netflix of peer support, right? This lecture will include the anatomy and a brief overview of the basal ganglia function, the ascending tracts from the skin right the way up to the brain in brief, the brainstem, both its external anatomy in brief and its blood supply, as well as the cranial nerves, with the exception of the second cranial nerve because you had questions on the visual field pathway and visual field defects in your first sit, so I doubt it will come up again. Okay, so every other cranial nerve will be mentioned. So let's begin with the basal ganglia. So you really need to know, in a cross section like this, where these bits and bobs are. Okay, so if I bring up my little pointer, we have a little caudate nucleus here. The caudate nucleus and the putamen together are called the striatum. They're called that because here's the caudate, right? Then the putamen's in here, and the striatum means stripy, like striated muscle fibers, and there's a stripy amount of connections of neurons here that connect the caudate to the putamen. So in this cross-section you can't see them, but they are actually connected. So the striatum is the caudate plus the putamen, its connection there. This lentiform nucleus, meaning lens shape or lenticular, lentil type shape, right, contains the putamen and the globus pallidus. And remember, the globus pallidus has both internal and external components, which are important for when you're looking at the direct and indirect pathway in the physiology. Then immediately you have the thalamus here. You have the subthalamic nucleus and the substantia nigra. This is the level of detail you need to know. With the internal capsule here, ventricles, canals there, that's basically what you need to know. There's nothing else you really need to know here. You also need to know it in this transverse section. So make sure you can pick them out on a schematic, okay? So for example, the corpus callosum you need to know here. You need to know here's your caudate, the head of it, and the tail is down here. And you need to be able to pick out this lentiform nucleus again. Putamen, globus pallidus with the thalamus medially here, okay? If you can do that, you're absolutely golden. Just make sure that you can see those particular things. Don't worry about all these bits and bobs. This is what Tunstall's looking for, these things here. Okay? So, the take-home message, THM, is that the basal ganglia is comprised of these 6 things. Locate them on the prosections. Make sure you can find them. These are the 6 things you need to know. So what I've done here is a little schematic. This is pulled from another lecture I made a few years ago in Manchester. So the fluffy cloud up there is your corpus callosum, your cerebral cortex, sorry. And then here's your lentiform nucleus, so your putamen, your globus pallidus, externus and internus, and then your thalamus. So the direct pathway turns on movement. It permits movement. So the cerebral cortex says, I want to move, and sends a positive fibre into your lentiform nucleus. And if your putamen says it's okay, it turns off. It sends a negative fibre to the GPI, the globus pallidus internus. And that's because your globus pallidus internus is the brake, right? It wants to stop movement. And that's really important Because if the globus pallidus internus gets its way, and this is the take-home message of the basal ganglia, if the globus pallidus internus gets its way, it shuts up the thalamus, so no permission slip is sent to the cerebral cortex, and movement cannot happen. So what are we going to do instead? We're going to say, okay, that's fine. So the putamen is going to actually shut off this handbrake, so that movement can occur. So because of that, there's no negative signal sent, so a positive message can rebound, okay? So actually you don't even need this wire at all, because you've turned off the globus pallidus internus, so you've turned off this. So no signal is sent, which means the thalamus can fire. And that's your direct pathway. Your indirect pathway, by contrast, the cerebral cortex says, hey, I want to move, but indirect is no movement. I don't allow it. It's not allowed. You're not going to get a permission slip. So the putamen, instead of sending a fibre to the internus, sends it to the externus. And the globus pallidus externus turns off the subthalamic nucleus. So what's going on here? Well, the subthalamic nucleus, well, okay, so the globus pallidus externus wants to turn off the subthalamic nucleus here. Okay, that's its job. So just like we said, the putamen's job is to turn off the globus pallidus internus, it can also turn off the globus pallidus externus. Okay? And the globus pallidus externus wants to turn off the subthalamic nucleus here. So what happens when the cerebral cortex says, hey, I want to move? So it sends a fibre like that. I want to move. Well, the putamen has a choice now. So the putamen's deciding, are we going to move? If we're going to move, I'm going to turn off the globus pallidus internus. If we're not going to move, I'm going to turn off the globus pallidus externus. So watch what happens. The putamen turns off the globus pallidus externus, which means that the globus pallidus externus cannot turn off the subthalamic nucleus. So the subthalamic nucleus turns on GPI, and GPI, remember, is the handbrake and wants to turn off the thalamus. So now the GPI is free to fire and turn off the thalamus, which means no signal is sent to our cerebral cortex. Nothing. So the permission slip, hey, I want to move, turns into a no. Okay, so just as a recap, hey, I want to move, putamen turns off the GPE, which means the handbrake of the subthalamic nucleus is gone. So the subthalamic nucleus turns on, and it turns on the GPI, which is the handbrake that turns off the thalamus. Complex pathways here, and it's actually much more complex than that, but your basic idea is if the direct pathway is turned on, you move. If the indirect pathway is turned on, you can't move. So jumping out of the brain now and into the ascending tracts. So ascending tracts carry sensory information about the outside world of all types to your brain, if you're going to be consciously aware of it, and to your cerebellum, if you're not going to be consciously aware of it. There are loads of tracts, there's about a dozen tracts. You only need to know 3, fantastically. As we said, if it's going to the brain proper, okay, if it's going to the brain proper, you're going to be consciously aware of it. If it's not, it's going to the cerebellum, and you will not be consciously aware of it. So the Spinocerebellar Tract, the cerebellum, so fibres come in, go up the brain, up the spinal cord and into the cerebellum, you will not be aware of it. But if fibres come in and ascend all the way to the brain, such as in the dorsal column and spinothalamic tracts, you will be aware of it. So that's something to bear in mind. So spinocerebellar conveys unconscious proprioception, so that's your knowledge of your position in space. So if you close your eyes, you know that you can touch your nose, and that's because proprioception means that you have a map inside your brain of where your body is in space. You know where your limbs are in space. You can put your hands together when your eyes are closed because you don't need the vision, because you have proprioception. You know where your limbs are in space. That's vital for balancing and not bumping into things. Your dorsal column medial lemniscus conveys conscious proprioception to the brain and vibration sense and light touch, but don't worry too much about that. It's mostly proprioception that we're concerned with. The spinothalamic conveys conscious pain and temperature and crude touch. There's actually two spinothalamic tracts, an anterior one and a lateral one, but the anterior one has only been proven to exist in cats. So make of that what you will. But there's those three tracts. An unconscious one funneled to the cerebellum, and conscious ones funneled to the brain. So you need to know where these are. So spinocerebellar, yep, conveys unconscious proprioception to the cerebellum. The spinocerebellar tracts do not decussate. That means they don't cross the midline. They stay on the same side. And the spinocerebellar tracts run in the lateralmost portion of the spinal cord. They're unconscious. I like to think they're out of sight, out of mind. They're out of the way. The spinocerebellar tracts run out here. Okay? They stay out here. The spinal level that they come into is where they start to ascend, they go up, and then they go through this thing called the cerebellar peduncles, and a peduncle, like having a pedicure, pedis, means feet, okay? So they go through the cerebellar peduncles, which stick out of the back of the pons, into the cerebellum, okay? So they stay on the same side, so left-sided spinocerebellar information goes to the left hemisphere of the cerebellum. So, what about the dorsal column medial lemniscus system? Well, so as we said, this is conscious proprioception to the brain, and it sits at the back. So we've said that the spinocerebellar is here, and our dorsal column medial lemniscus system is there. Okay, the medial one is gracile, and that's because it's slender. So it's supposed to look thinner than the other one. It's basically this region here, the gracile nucleus. And that is the lower limb. So it's the lower limb, whereas the lateral bit here is the cuneate, and cuneus means a wedge shape, like it's some sort of wedge, like it's wedged in and it's stuck. And that's because it's said to be wedged between this grey horn here and the gracile nucleus here. So it's sort of like crammed in, so it's called the cuneate, or the wedge one. And this is the upper limb, so lower limb and then upper limb. Okay? So, it's synapses at the medulla oblongata. So these are long neurons, okay? They come into the spinal cord. Let me try and draw on here. They come into the spinal cord like this, and then they run to here, and they run all the way up till they find the medulla oblongata, and they stay on the same side for that course. So throughout the spinal cord, the dorsal column medial lemniscus system is ipsilateral for that reason. Synapses in the medulla oblongata. Okay, it decussates at the base of the medulla oblongata and then runs to the thalamus, the ventroposterolateral nucleus, if you care about that, but I wouldn't care too much about that. It runs to there, and then a third order neuron emerges that goes to the primary somatosensory cortex. Okay, so make sure the DCML is very high yield, so do make sure that this is something that you're nice and comfortable with. Okay, so let's just review it here. So we have our dorsal root ganglia. The fibers come in and they run to either the gracile if it's lower limb or cuneate if it's upper limb. Right the way up to here, this is our medulla oblongata, where they synapse on nuclei of the same name. So a gracile nucleus and a cuneate nucleus. They then cross at this decussation here, this internal arcuate fasciculus it's called, but you don't need to know the name, and then it runs up in this green column called the lateral lemniscus. So this is the lateral lemniscus, so it's called the dorsal column because they're in the back, the dorsum of the spinal cord. Dorsal column, sorry, it's the lateral lemniscus, didn't I? Dorsal column medial lemniscus, so this is the medial lemniscus, the green, and then it runs up, up, up. It's sort of in the middle to the side of the brainstem. 1, 2, 3, and then up to the ventroposterolateral thalamus, and then a third order neuron goes to the cerebral cortex. With that homunculus arrangement, remember, you can see the stroke lecture for a lot more information about the homunculus arrangement. So, here's our gracile fasciculus, and here's our cuneate fasciculus. So make sure you're aware of those. And then here, just as a recap, will be our Spinocerebellar Tracts. So we've got one more, Spinothalamic Tract, and this conveys conscious pain and temperatures to the brain. And it's sort of here. So whereas the dorsal column was here, and the Spinocerebellar Tract was here, This region is more the remit of the spinothalamic tract, okay? So it's totally fair game for a pin to be stuck on a picture of the spinal cord, you know, if a lesion occurs here, what's going on, or which type of fibres travel in this area of the spinal cord, or, you know, that kind of thing could totally come up. So, lateral spinothalamic tract, pain, temperature, and crude touch. Now, the neuron comes in to here, and then synapses at a region called the substantia gelatinosa, which literally means a jelly-like substance, because the early anatomists didn't know what it did, but saw it on a microscope and was like, oh, that looks like jelly, so I'll call it the substantia gelatinosa. Which doesn't help us, but basically it's a pain modulator. There's loads of opiate receptors in there, and if you're trying to be stoic and not think of pain, it can actually turn off the pain impulses from the outside environment to the spinal cord at this point. But if a second-order neuron does emerge, it's pain you need to know, then it comes and it crosses the line here, and then it will run into this lateral corticospinal tract, which will be about here, lateral spinothalamic tract here, and then run all the way up as a second-order fibre. And that goes all the way, let's see, decussates at the same level of the spinal cord, which we said, as a second-order neuron, and then ascends directly to the thalamus to synapse. Okay, the third-order neuron is now from the thalamus, again to the primary somatosensory cortex, just as we said. So just to make sure, here's our dorsal column-medial lemniscus tract. So in it comes, blah, 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 and then it goes to the gracile or the lacuneate fascicles, all the way up in the dorsal column, synapses at the bottom of the medulla, decussates over and then runs in the medial lemniscus to the thalamus and then up to the primary somatosensory cortex. So that's your first-order neuron, your second-order neuron, and your third-order neuron. So you could be asked a question, where does the second neuron of the DCML start? Well, follow it up. Here's your first one from the skin, all the way up, and it synapses here at the base of the medulla. So the answer would be the medulla, right? So what about the spinothalamic tract? Pain and temperature sensation and crude touch sensation. So the first order neuron actually ends at the spinal cord. So here's a difference that an MCQ could give you, right? The first order neuron ends at the substantia gelatinosa of the spinal cord here versus the medulla there. It decussates over here, and then runs in the lateral spinothalamic tract to the ventroposterolateral thalamus, and then up to the primary somatosensory cortex, like so. So these are the different tracts you need to know. You need to know where they are. So spinothalamic's here, and then lateral to it is our spinocerebellar, and then at the back here is our dorsal column. So spinocerebellar, out of sight, out of mind, because it's unconscious, so it's pushed to the side. Dorsal column says it in the name, is it the dorsal column? Lateral spinothalamic tract, because it's lateral, but it's not quite as lateral as our spinocerebellar tracts. These pictures, by the way, are pulled from the MRCS, Member of the Royal College of Surgeons Anatomy books. So even when you're training to be a surgeon, you do not need to know more detail than this. These are from the anatomy books they learn from. So you're at the apex of what you need to know, so don't worry too much. So, halfway through, I'm going to crack straight on into the brainstem. So if we turn the lights off... Oh, I don't know how this is going to work, actually. No, I don't have control. Oh. So here is our brain. And if you look, you can find the brainstem, but I'm not going to be able to pause it in time. So let's do this instead. So here's our midbrain, here's our pons, and here's our medulla oblongata. Okay? Now, cranial nerve 1 emerges from the nasal cavity, runs through the cribriform plate, and then runs up to the brain here, roughly where the uncus is. That's cranial nerve 1. Cranial nerve 2 emerges from the thalamus region here, and goes to the eye. Cranial nerve 3 comes out of here. Cranial nerve 4 comes out of the back of the midbrain. Cranial nerve 5 comes from the side of the pons here, and we'll stop there because they all get a bit muddled up around here for the rest of them, so we've not got enough space. But rest assured that what you need to know at this point is that cranial nerves 1 and 2 do not come from the brainstem. Okay? The lower 4, 12, 11, 10, and 9, the lower 4 come from the low bit of the brainstem, which is our medulla, right? So cranial nerves 12, 11, 10 and 9 from the medulla, and then 8, 7, 6, 5 from the pons, and then what's left? 4 and 3. So cranial nerves 4 and cranial nerves 3, but make sure you know the Roman numerals. They come from the midbrain. That's about as easy as I can make it, but let's make it a bit harder. So, blood supply. I didn't draw this, I pulled it from Google, but I think it's fantastic. So here's our spinal cord, and we have our anterior spinal artery and our posterior spinal artery. This isn't quite true. So most texts have that the anterior spinal artery covers this whole region here, for the most part. Maybe a little bit less. Maybe to about here. Okay, so that's our anterior spinal artery, and then the back here is our posterior spinal artery. So that's the blood supply. So what supplies DCML? Posterior spinal artery. What supplies the Spinocerebellar Tracts? Anterior spinal artery for the most part. Okay, moving up. If we look at the bottom of the medulla, the caudal medulla, you've still got anterior spinal artery, and you've still got posterior spinal artery, but we now have a contribution from the vertebral artery. Okay? You've still got, at the top of the medulla, the anterior spinal artery. You've still got the vertebral artery, but now you have PICA, posterior inferior cerebellar artery. As we move further up, all you need to know about the pons is that it's supplied by the basilar artery. That's great, it's got one artery here. And then AICA, the anterior inferior cerebellar artery, supplies the peduncles more laterally, but that's not the brainstem, is it? So don't worry about that. And then the midbrain itself is supplied by a bit of the basilar artery, or it could also be said to be supplied by the superior cerebellar artery. And then at the back, it's the posterior cerebral artery. There is a lot of variation in this, though. Okay, so make sure you can draw the circle of Willis, but there's a lot more information on the blood supply of the brain in my stroke lecture, so go and have a look at that. So we've already covered this, all of the nerves that come off the brainstem. So make sure you can have a look at this and you can say, yeah, I know which nerve is which, because they could give you a picture of a brainstem and put a pin in it and say, which nerve is this? Yes, so let's jump straight into the midbrain. So all these labels, terrifying, right? But there's very few you need to know. So you need to know that there are anterior descending motor fibres. These are your corticospinal tracts going to the spinal cord, and corticobulbar tracts going to your cranial nerves. Okay, and they run at the front in these peduncles, these cerebral peduncles. Anterior red nucleus, let's paint this in red here. This giant red nucleus. Yeah. And then anterior substantia nigra. So the substantia nigra is this portion here. So this is also what you need to know. You'll never need to know more than this unless you're going to do neurology. So those are the key things you need to know. What I will also throw on here is that you have your dorsal column, which remains near the back. Oh, sorry, no it doesn't, because you're in the medial lemniscus now. So you've got your medial lemniscus fibres here, as well as your spinothalamic. So they've kind of merged here at this point. This is very simple, but yeah, they've kind of merged. Yes, so make sure you're aware of those things. Here's the medulla, and that's a simplified version of the medulla, let me tell you. I had to memorise that once upon a time. Good God. Okay. Yes. So remember about the the pons. My God. So remember about the pons. That the pons connects. So remember. Let me. Oh God. Let me draw our brain nice and quick. So remember that our pons here is the thing that connects to the cerebellum. So the midbrain and the medulla don't really. They do a little bit, but not much. It's mostly the pons. So the pons have these massive cerebellar peduncles that plug directly into the thing. So this is actually a picture of the medulla. I don't know why I've added that. So anyway, yes. So the pons connects to the cerebellum via the cerebellar peduncles. Yep. The fourth ventricle sticks out at the back of the pons. Okay? And then what you need to remember at the inferior pons, the pontomedullary junction, that's why I put this picture in here. So at the pontomedullary junction, the corticospinal tract, those descending tracts cross here. There's a big cross that occurs just here. So this is just sliced just below that. Okay? And now here's our medulla. So, in the medulla, you need to know about a couple of things. So you need to know the nucleus ambiguus. So ambiguous is A for action, because it's a motor nucleus, and it's motor to cranial nerves 9 and 10. The nucleus ambiguus is here. This is the nucleus ambiguus. Sat there. You won't need to know where it is, just what it does. Motor to 9 and motor to 10. The nucleus solitaris, solitary is sensory to 8, 9 and 10, because you've got cochlear nuclei here, vestibular cochlear nuclei here. They border both the pons and the medulla, and they sit in the back corner of the pons and the medulla. So it's sensory for 8, 9 and 10. We'll do a bit more detail on that later. And remember that the site of the dorsal column-medial lemniscus synapse is here, so our gracile and our cuneate nucleus, cuneate, gracile, that's an accessory cuneate, but don't worry about that. Gracile, gracile, cuneate, and then the decussation. So you can't see it at this level really, but fibres cross over. In fact, you know what? I've inverted this completely, haven't I? Yeah, I mean, it's deep enough that you can see it, so don't worry about that. So it's deep enough that you can see it. So you've got your nucleus ambiguus, you've got your nucleus solitaris, and the nucleus solitaris is actually here. It's actually embedded within the dorsal, what's left of the dorsal column here. The nuclei have kind of obscured it. That's why it's called the solitary nucleus, because it's kind of on its own in a sea of other things. So that's basically what you need to know. Okay, you need to know which cranial nerves emerge from which level, and the couple of extra things like the nucleus ambiguus for action for 9 and 10, and the nucleus solitaris for sensory for 8, 9 and 10 in the medulla. That's basically the level you need to know, and then remember the major bits of blood supply. Okay, so cranial nerves. Very brief overview of the cranial nerves. So cranial nerve 1, where does it go? Well, it comes from the nasal cavity here, and then it runs through this cribriform plate of the ethmoid bone up to this bit called the olfactory bulb. From the olfactory bulb towards the brain is the olfactory tract. So the olfactory tract here runs along the base here into a bit called the uncus. Uncus means hook shape. So here's a medial section of the brain, and then just in this parahippocampal gyrus here, there's a little bump. That little bump here is called the uncus. There's the hook. So there's your first nerve, there's your optic tract, and it runs and then it hooks into this uncus here. Ooh, that's a bit funky. What does it do? So, olfaction, obviously. A few other things. Does it do pheromones for humans, doesn't it? Big debate that we don't care about. So, clinical correlates. So if you have a fracture of the anterior cranial fossa, see the brain and skull lecture for more information on that, it will cause anosmia. No smell, anosmia. Nose, yeah. You can also have a meningioma or meningitis affect smell too, because this region receives a sheath of dura mater, so it's actually encased in meninges. So if you get meningitis or a meningioma, a tumour of the meninges, then you will get compression and anosmia as a consequence. Let's try and skip on. So, cranial nerve 3. So, got a little key at the bottom here. Whoops. So, cranial nerve 3, the oculomotor nucleus. So, what's its course? So, it runs through the cavernous sinus, which we'll talk about later, but for now, here's our midbrain, right? So, actually, a quick spot check here. We can see that here's the peduncles of the midbrain that have the descending fibres. Here's the substantia gelatinosa. Here's our red nucleus, and here's our the cerebral aqueduct with the periaqueductal grey. The periaqueductal grey is full of opioid receptors as well, so that's about pain modulation as well. So third nerve comes out of here and then runs through the cavernous sinus to pop out of the superior orbital fissure. So through the cavernous sinus to pop out through the superior orbital fissure. Don't worry if you don't particularly know where they are. Here's where the pituitary gland sits. So the pituitary gland sits in here, in the sella turcica, and then either side of the pituitary gland is a sinus, a depression, that's called the cavernous depression because it's like a cavern, it's so big. Okay, that's either side of our pituitary gland that is sat in here. So, the mnemonic to remember the extraocular movements, the movements of the eye, is LR6, SO4, AO3. So LR6, lateral rectus, is innervated by cranial nerve 6, SO4 by cranial nerve 4, AO3, all others, cranial nerve 3. Right? So basically, if you've got multiple problems with eye movement, it's more likely to be cranial nerve 3, because the 6th nerve only innervates one muscle, 4th nerve only innervates one muscle, and all the others are innervated by 3rd nerve. Yep. So it innervates something called, well, all of the other muscles, all of the other extraocular muscles that are not the remit of this lecture, but also levator palpebrae superioris. Now let's unpack that. In fact, let me write it. Levator palpebrae palpebrae superioris. So levator elevates palpebrae, the eyelid, superioris, superiorly. So it opens the eyelid, right? Elevate the eyelid, right? So it opens the eye. So if I lesion this nerve, my eyelid doesn't open properly, so what happens? It droops. And what's the medical term for a droop? Ptosis. P-T-O-S-I-S. Ptosis. So the patient gets ptosis. The other thing is that it innervates the sphincter pupallae muscle, so the thing that makes your eye smaller. Now, we won't go into the pupillary light reflex, but rest assured that cranial nerve 2 detects light, sends it to your midbrain, and cranial nerve 3 comes out of the midbrain here, and then runs to, does a whole load of things, goes through ganglia and stuff that you don't need to know about, and then goes straight to that sphincter to make your pupil smaller. Because, hey, cranial nerve 2 is like, whoa, you're staring at the sun, close the pupil so he doesn't burn his retina off. So that's sphincter pupallae. Obviously, this is a very, very truncated thing. I could give a lecture for each cranial nerve that takes an hour, but we can't, so... The patient will have down and out syndrome. So when all of AO3, when all of the other... what's happening? When all of the... when all of the other extraocular muscles, apart from lateral rectus and superior oblique, are turned off, then what's left is the eye goes down, it depresses, and then it turns out. So it abducts, down and out, because superior oblique lowers the eye, and lateral rectus turns the eye laterally. Okay, so you get AO3. So the eye looks down and looks out on one side with a ptosis. So a complete ptosis or a partial ptosis, depending on how badly the nerve's lesioned. You pull open the eye, and then it's down and out. You let go and the eyelid droops down. There's also no third nerve action on the pupillary light reflex, same side. So you shine a light in the eye and it does not constrict. The other side will constrict because second nerve's fine. Second nerve's not lesioned if third nerve is lesioned. So you shine a light in that eye and second nerve conveys it to the midbrain, and then third nerve is supposed to constrict both at the same time to be efficient, but it can only constrict the other eye. So that eye with the third nerve lesion, there'll be no innervation to the sphincter pupallae, and as a result there will be it will just be dilated, it'll be fixed, right? So, cranial nerve 4. Cranial nerve 4 is the longest cranial nerve that we're going to talk about, apart from the vagus nerve. It has the longest course in the skull, in particular, because it pops out of the back. So, unlike third nerve, which starts about here, right? And so third nerve, it starts a bit higher up, but third nerve starts here and then runs like that. This one starts here and then runs to the other side, to the back, and then out. So trochlea is a pain in the arse, really. It's long, and it decussates to the other side. So if this is our left trochlear nerve, it's innervating the right muscle. Okay? But remember, LR6, SO4, AO3. LR6, SO4, it's fourth cranial nerve, AO3. So what's that telling you? Well, it's telling you that it's going to be innervating the superior oblique muscle. Spoilers though, eh? So through the cavernous sinus again, and through the hole called the superior orbital fissure. If these don't mean anything to you, watch my lecture on the skull and brain and it will tell you. The function. So it decussates within the midbrain itself to the contralateral superior oblique muscle, which depresses the eyeball. Okay, part of that down and out depresses the eyeball. It makes you look down. So everyone look down at your desk now, and you've just turned your trochlear nerves on. So, extorsion. If it doesn't work, and you get extorsion, which is a twisty thing, you also get upward deviation. But this is the most important thing, so don't worry so much about that. Upward deviation is what you get, right? So if you can't look down, then unopposed movement of looking up happens. So the patient's eye will drift up, and if they try to pull it down, it's not strong enough to overcome it, so it'll keep jumping back up and up and up, which means that when you tell the patient who's looking up and can't look down to look down a little bit, well then they try to pull it down, but this really strong muscle is pulling the other way. So they'll get a bouncing up and down and up and down and up and down of the eye, and that's called a vertical diplopia. Diplopia, double vision, vertically. Okay? So, cranial nerve 5. Cranial nerve 5 has 4 nuclei that it originates from. One of them is in the midbrain, one of them's in the pons, and one of them's in the medulla, and then here's another one in the pons. So, let's break this down, shall we? So, from the pons, and midbrain, and medulla, there's 4 nuclei, 3 sensory, 1 motor, and they all come together at the pons to form one trigeminal nerve that goes to the trigeminal ganglion. From the trigeminal ganglion, they split 3 ways into V1, V2, V3. Erin calls them VA, VB, VC. Most texts have them as V1, V2, V3. I've never called them VA, B, and C in 10 years of anatomy. But Erin likes A, B, and C, so call it whatever you want. Ophthalmic, maxillary, and mandibular. Okay? So, they go out of holes, the superior orbital fissure, the foramen rotundum, and the foramen ovale. Now, if you're not an anatomist, I don't expect to memorise that, so there's mnemonic. Cranial nerve 5 leaves the skull because it's standing room only in the theatre. Okay, so it's S, standing, superior orbital fissure, R, room, foramen rotundum, and then only is ovale, foramen ovale. So out the pop. Right? The sensory supply is, I call it CAT, so you can remember it, because everyone remembers this, the sensory supply, so up to the tip of the head. It's not actually that far back, but up to the tip of the head. V1 covers right the way to the tip of the nose here, and manages to get the eye in. So the cornea, if you tap the cornea and it makes you blink, that's because fifth nerve is working. Anterior 2/3 of the tongue, and that's the sensory, not the taste, because taste is 7th nerve. Anterior 2/3 of the tongue, and then teeth. It grabs both arcades, the upper arcade and the lower arcade. The motor supply will be mastication or chewing, and that's usually the ruminative temporalis, a big muscle up here, and masseter. And masseter comes from your zygomatic process here, down, grabs the mandible and makes a big bite. They're huge on rats because rats, chew. And cows, they're huge on cows as well. So, a thing to realise about this is that the upper fibres coming from the brain decussate. So, the left-sided brain talks to right-sided nuclei. So, there's a decussation for loss of pain temperature. So, your left-sided trigeminal nerve lesion is going to affect right side. Yeah? And vice versa. Okay? And then, so you'll have pain and temperature contralaterally at the face, either as V1, V2, V3, or if it's more proximally, so before the trigeminal nerve here, so in between, so I should say in between the trigeminal ganglion and the brainstem. If it's here when they're all one nerve, then V1, 2 and 3 are affected. If it's out here, more proximally, if it's V1, 2, V3, then they'll have specific lesions to these regions, and then masticatory loss, as we've said. And this is a beautiful illustration that just lets you know. You don't need to know all of these branches, thank God. Save that for the anatomist. You just need to know that here's V1, going to the ophthalmic region, here's V2, going to the maxilla, and here's V3 going right down to the mandible. It's a very precipitous course out of the bottom of the skull. So you've got two reflexes here. You've got your blink reflex, so blink, which is the anterior limb, is the cornea, which is fifth nerve, as we've said, V1. And then down here, if I tap on this, it's V3, the mandibular nerve, that picks up this tap. That's V3. And then the efferent limb of this is V3 to the masticators. The efferent limb of this is seventh nerve. So V1 is the afferent limb, and then seventh nerve is the efferent limb, and V3 is the afferent limb and the efferent limb of this reflex. And both of those reflexes are on your cranial nerve osci. So, cranial nerve 6, the abducens nerve, also goes through the cavernous sinus, hence the picture of the cavernous sinus. So it comes out of the pontomedullary junction, runs through the cavernous sinus, through the superior orbital fissure, and then out to LR6, SO4, AO3, so the lateral rectus muscle. Okay, so it's the abducens nerve because it abducts the eye. That's why it's named that. So it turns the eye laterally. So what's going to happen if it's not working? The eye will turn medially, because the medial pulley is unopposed. So the eye turns medially. Boom. Now, as soon as I see an eye turning medially, a convergent movement that's unopposed, my first concern is this an aneurysm to the internal carotid artery? And you're thinking, what the hell is he on about? Well, here's the cavernous sinus. So we have the pituitary gland here, as we said, and lateral to that is our cavernous sinus. In the wall are loads of cranial nerves, right? Cranial nerve 3, cranial nerve 4, V1 and V2. Cranial nerve 3, 4, 5, 5. So nice and simple. But cranial nerve 6 sits a lot closer, actually. Sits about here, under the internal carotid artery. And this thing, because of gravity pooling, when it has an aneurysm, it tends to pool down here. So the aneurysm, a bulge of the artery, particularly if they've got, say, Marfan syndrome or Ehlers-Danlos syndrome, some connective tissue disorder, the internal carotid artery is going to bulge and push down on it and compress sixth nerve. Now, if I've got a patient with a connective tissue disorder or really bad hypertension and they have a squint that goes in like that acutely, and then they start to get completely paralysed muscles, and they can't move their eye at all, I'm thinking, oh God, this patient's internal carotid artery is either massively expanded or exploded into the cavernous sinus, and then they go into hypovolemic hemorrhagic shock. So, anyway, let's turn that down a little bit. So, lateral rectus 6, so abduction. So if I try to get this patient with a sixth nerve lesion to turn their eye to the right, to abduct their eye, abduct that globe, then it'll snap back because it's not strong enough to abduct. So we get a horizontal diplopia. So this is in contrast to the superior oblique not working, and you get a vertical diplopia. So LR6 gives you a horizontal diplopia, SO4 gives you a vertical diplopia, and AO3 gives you down and out. That's just word association to learn. Okay? We are almost done. Let's do the facial nerve. Cranial nerve 7. So cranial nerve 7, so this is 7th nerve nucleus. So that 7th nerve nucleus in the brainstem. Also, the superior salivatory nucleus. Now, the superior salivatory nucleus does all of those salivatory glands. Remember your submandibular, your submentals, there's loads of accessory salivary glands, von Ebener's glands they're called, that are throughout the mouth, throughout the buccal cavity. But it doesn't do the parotid gland. The parotid gland is cranial nerve 9, which is a pain in the arse, but we'll get to that. Right? So, it runs through the facial canal and out of the skull. Pops out, and that's the temporal bone. So it runs through the facial canal and out of the skull. Now, it does do a couple of things that you need to know. It does facial expression. All your facial expression is seventh nerve, okay? And there's 5 branches that you don't need to know the names of. That's what the abbreviations are here. I'll give you them. So temporal, zygomatic, buccal, marginomandibular, and cervical. You don't need to know that unless you're an anatomist, so bye-bye. So it's going to do facial expression. Tears, that's seventh nerve. So if the patient can't cry on one side and they can't move their face on one side, you're thinking, oh dear, there's a seventh nerve problem going on here. And that's the greater petrosal nerve. The greater petrosal nerve supplies your lacrimal glands that make you cry. Taste to the anterior 2/3 of the tongue. So here's our tongue. Let's draw a tongue. So the anterior 2/3 of the tongue and the posterior 1/3 of the tongue. Now, tongue always comes up. So 5th nerve is sensory. 7th nerve is taste. So don't forget that. And then, so that's carried in a little structure called the chorda tympani. And we have this thing which gives a branch to the stapedius. A branch to the stapedius. It's called the stapedial nerve. And the stapedius holds the ossicles in place so they don't overreact to loud noise. Right? So the stapedial reflex kicks in from the brainstem when it hears a loud noise. It kicks in, bang, holds the ossicles in place and prevents noise from being too loud. That's called hyperacusis. So why am I like going to town on this? Well, it's because this tells you the defects. If you understand the anatomy, you understand the defects. So you can't cry, lack of tears, right? Lack of tears. Lack of facial expression. Lack of taste to the anterior 2/3 of the tongue, and hyperacusis, hyperauditory, hyperacusis, right? Now, here's the age-old medical student's dilemma. Upper motor neurons and lower motor neuron lesions. So, from your puffy brain up here comes an upper motor neuron, okay? And the upper motor neuron synapses on the top and on the opposite bottom, right? Does that make any kind of sense to you? So, let's say this is the right side, and the right side brain supplies both 7 nerve nuclei at the top, but only the contralateral bottom. And it's the same on this side. So both on the top and only the contralateral on the bottom. And what this results in is a phenomena called forehead sparing. So, remember that we said the top gets dual supply, but the bottom only gets one supply. So if you cut one wire from the left or right side, the top doesn't care because it has supply both sides. But the bottom only has supply from one, right? So this patient here with a central facial palsy has drooping because she has an upper motor neuron lesion on this side of her brain like a stroke. You know it's upper because there's forehead sparing, because when you say, look surprised, lift her eyebrows up, she can make these furrowed creases. Okay, so it's worth spending a bit of time to think about that. Now, 8th nerve will do nice and quick. So this comes from the vestibular apparatus in the inner ear, and then runs through the internal acoustic meatus to the pons. It's involved in hearing, which is the cochlear part, and the vestibule is balance. And to test the vestibular reflex, you do the whole pike maneuver, which is where you rotate the head to the side and then lie the patient down and then bend their head backwards. And if they start to get vertigo or a nystagmus going on, then there's something wrong with that system. But don't worry about that until second year. You certainly wouldn't be asked to do that in the OSCE. The cochlear supply is tested, the sound, by Weber and Rinne. Weber placed on here, and then Rinne test here. So you strike, and then you place it on the mastoid. And that's distinguishing air and bone conductance for conductive hearing loss here. And you use Weber to distinguish between conductive and sensory neural hearing loss. Don't worry too much about that, honestly. So, 9th nerve, glossopharyngeal nerve. So the course is ninja. So it comes from 3 different things, ninja, N-I-N. Nucleus of the solitary tract, which we mentioned, S is sensory to 8, 9 and 10. And nucleus ambiguous is A for action, motor for 9 and 10. And then the inferior salivatory nucleus, I've just told you what that does, if you remember, the parotid gland. Okay, so inferior salivatory nucleus of the parotid gland. So superior salivatory nucleus is all of them, except for the one at the inferior salivatory nucleus. So all except one inferior salivatory nucleus is parotid. So this is cranial nerve 9, and this is cranial nerve 7, like so. So the function of cranial nerve 9 is very widespread, as you can imagine, okay? But I like to think of the 3 Ps for sensory. So it supplies the pharynx, it supplies the posterior third of the tongue, and that is both taste and sensation. So unlike the front of the tongue, which is 5 and 7, 9 captures everything at the back. And then this thing is interesting, pressure and chemoreception. Do you remember that you have your carotid sinus, your carotid bodies, your aortic arch, which convey pressure and chemoreception information via cranial nerves 9 and 10 to the nucleus solitaris. So the nucleus solitaris is one of the places that decides, along with the nucleus ambiguous, your blood pressure. So that's very important. It's part of the cardiorespiratory centre. And then 2 other key things to remember about the 9th nerve is that it has parasympathetic, secreta motor to the parotid gland, and a motor supply to stylopharyngeus. Just that spelled wrong. Pharyngeus, one muscle in the laryngopharynx there. Just one of them. Yes. So, therefore, if you lose pharyngeal supply of cranial nerve 9, you lose the afferent limb of the gag reflex. So you poke the back of the throat and nothing happens. The patient doesn't gag or choke or cough, right? You also lose autonomic control of chemobaroreception because you can't make decisions, you can't send that information in. Now, there's some collateral supply with 10th nerve that also does it a bit further down in the aortic region as opposed to the carotid region. So there's a bit of gain of function, but you lose quite a bit of autonomic control of chemobaroreception, so you're going to have really weird blood pressure things going on there. 10th nerve. Vagus means vagrant, the wanderer, the travelling wanderer, because it's enormous. It supplies the tiny bit of the head, loads of the neck, loads of the thorax, and loads of the abdomen, up until 2/3 of the way along the transverse colon that's not animated on this picture. Oh yeah, it is. So it goes to here. So this picture's wrong. So it stops there. That's as far as it gets, to the end of the midgut. And Tunstall loves to ask you questions about the division of the foregut, midgut, and hindgut, so make sure you know that, right? So 10th nerve originates, we've said in the NST, nucleus of the solitary tract for sensory, nucleus ambiguous for motor, but because it's so big, it gets an extra motor one. The dorsal motor nucleus of cranial nerve 10, DMNX, the neuroscientists will call it. The dorsal motor nucleus of cranial nerve 10, that helps with powering peristalsis, with powering cardiorespiratory functions. It's just a bit of extra oomph for this far distance it's got to go. So it travels out via the jugular foramen to the palate, to the pharynx and the larynx, and ends all the way at the midgut here, all the way. So it's going to do a couple of things. So the nucleus of the solitary tract, as we said, is solitary for sensation, so it's sensation, as well as taste. There's a little bit of taste in the pharynx. Nucleus ambiguous for action, and dorsal motor nucleus for motor. So actually, this is a classic example of when things were discovered. What was the tradition? So nucleus ambiguous, because the anatomists were in charge, and they said this is an ambiguous-looking nucleus that we don't understand the function of, so we're going to call it the nucleus ambiguous. This is the nucleus solitaris, because it's in solitary, it's sat on its own, where there's nothing else with this stain that we've got that's around it, so we're going to call it the nucleus solitaris. And then along comes the neuroscientist to name this later on when we've got a bit more technology, and they say, oh, hang on, it's dorsal, it's at the back, it's motor, nucleus to cranial nerve 10. So I remember what it does, I'm going to name it for its function. And isn't it great when they do that? So dorsal motor nucleus of cranial nerve 10 pairs with the nucleus ambiguous, which I think should be renamed, to supply the larynx and pharynx motor supply. So you already can tell what's going to happen. If your larynx and pharynx can't move, then you're going to have swallowing and speech issues if 10th nerve is lesioned, right? You're also going to get parasympathetic supply because it's the big parasympathetic nerve to the thorax and the abdomen. So peristalsis is not working properly, and the vagus nerve can't turn down your heart rate. So your heart rate speeds up, your breathing rate speeds up. So swallowing issues, voice issues, taste changes to the posterior third of the tongue, and all of those autonomics that we've slightly discussed there. Accessory nerve is dead easy, right? Accessory nerve, this comes from the cervical spinal cord. What? Yeah, it's actually not a cranial nerve. It was classified incorrectly, but because of dogma and history, we can't change it. It's not a cranial nerve. It's from the spinal cord. But it goes back through the foramen magnum and then out again via the jugular foramen. So that's how it picked up its name as a cranial nerve, because it briefly loops into the cranium, but it supplies nothing in the cranium, and it doesn't originate from the cranium. It just has a circuitous course because embryological structures pulled it into the brain case very briefly. So through the foramen magnum, then out again via the jugular foramen. And here you can see it just on its course here. This is 11th nerve. So here's sternocleidomastoid, sternocleido. Cleido is Greek for clavicle. So sternum, the clavicle, up to the mastoid process here. So it supplies SCM. SCM turns your head. And then trapezius here shrugs your shoulders. So it supplies SCM and trapezius. So have the patient turn their head and have them shrug their shoulders. But make sure they do it against resistance so you can test the power of this muscle. Okay? And finally, 12th nerve, hypoglossal. Glossus means tongue, so hypo means below. So it comes out here and then jumps under the tongue and supplies every single muscle of the tongue apart from one, just to be a pain. So 12th nerve nucleus comes from the medulla, because remember that we said the lower four, 9, 10, 11, 12, come from the medulla. Then the next four come from the pons, 5, 6, 7, 8. I'm trying to count backwards. That's a test of cognition, isn't it? And then the midbrain is cranial nerve 3 and 4. Cranial nerves 1 and 2 do not come from the brainstem, they come from the high brain. Yes, so out of the hypoglossal canal, which is right next to the foramen magnum either side, see my skull lecture for those details. Out of the hypoglossal canal, and innervates all tongue muscles apart from one, it moves the tongue. What a surprise, right? If the lesion, because it decussates, again, so because my motor cortex on the right-hand side controls the left side of my tongue, right? If I have an upper motor neuron lesion stroke, then it's going to decussate, the fibre will decussate, so the lesion will be contralateral, right? So the consequence will be contralateral. But if I have a lower motor neuron lesion to this peripheral nerve here, then it's going to directly affect this side of the muscle. So lower motor neuron is ipsilateral. So if the patient sticks out their tongue and it deviates to the right, it's either a right-sided lower motor neuron lesion or a left-sided upper motor neuron lesion because of decussation. So be careful if the patient sticks out their tongue and it deviates one way. It does not, so there's a thing that medical students learn called the tongue never lies. It points toward the side of the lesion, but it never lies if it's lower motor neuron. So lower motor neurons don't lie, not the tongue, so remember that. So that's it. That's Regroup. So hope that was helpful. Here is the QR code. It takes 30 seconds. Point your phone at it now. I'm always rubbish because I turn off too quickly, but point your phone at it now because feedback is super useful. I can use it for my portfolio, otherwise I get nothing for doing this lecture apart from altruism. So point your phone at this, leave some nice feedback, nice and friendly, and that's it. So we just made it under an hour. Thank you for listening, and don't forget to check out MedGuide, where we have 1,500 questions for phase 1 to help you practice, including this video will be on MedGuide, which you know if you're watching it from MedGuide. Please leave feedback. Any questions, my inbox is open. My email is on the feedback form. Thank you.